Welcome to the Immunology Serology lecture on the herpesviridae. Got herpes? Well then, you're in luck because you can collect all 8 herpes viruses. Yes, you heard right, all 8. The herpes viruses go by a variety of names. HHV1, which is human herpes virus 1, is also known as HSV1 or the herpes simplex virus type 1. Similarly, HHV2 or the human herpes virus 2 is known as HSV2 or herpes simplex virus type 2. Human herpes virus 3 is varicella zoster. Human herpes virus 4 is the Epstein-Barr virus. Human herpes virus 5 is CMV or cytomegalovirus. And then the remaining 3 are lesser common, not as common herpes viruses, HHV6, 7, and 8, although HHV8 is associated with Kaposi sarcoma. Herpes viruses are divided into 3 groups: alpha, beta, and gamma. The alpha herpes viruses include herpes simplex virus types 1 and 2 and varicella zoster virus. The beta herpes viruses include cytomegalovirus and human herpes viruses 6 and 7. And finally, the gamma herpes viruses include the Epstein-Barr virus and human herpes virus type 8. Members of the herpesviridae are classified as DNA viruses, specifically double-stranded DNA, and their genomes are rather large. They are all enveloped and contain clusters of proteins that line the space between the envelope and the nucleocapsid, called the tegument. They also enter into a latency period at some point following the initial infection. The most common human pathogens in this group include HSV1, HSV2, VZV, EBV, and CMV. Humans are the natural hosts for these viruses. Pictured here is an illustration of the herpes virus that depicts the 4 primary structural components: the lipid envelope, the tegument, the capsid or nucleocapsid, and the genome consisting of double-stranded DNA. Herpes viruses often get a bad rap in the medical community and the greater community at large, and deservedly so. However, there was a fascinating study that was published in the journal Nature in May of 2007 involving the Epstein-Barr virus and cytomegalovirus. I'm going to read an excerpt from that study, pretty much the abstract for the paper. All humans become infected with multiple herpes viruses during childhood. After clearance of acute infection, herpes viruses enter a dormant state known as latency. Latency persists for the life of the host and is presumed to be parasitic, as it leaves the individual at risk for subsequent viral reactivation and disease. Here we show that herpes virus latency also confers a surprising benefit to the host. Mice latently infected with either murine gamma herpes virus 68 or murine cytomegalovirus, which are genetically highly similar to the human pathogens Epstein-Barr virus and human cytomegalovirus, respectively, are resistant to infection with the bacterial pathogens Listeria monocytogenes and Yersinia pestis. Latency-induced protection is not antigen-specific but involves prolonged production of the antiviral cytokine interferon gamma and systemic activation of macrophages. Latency thereby upregulates the basal activation state of innate immunity against subsequent infections. We speculate that herpesvirus latency may also sculpt the immune response to self and environmental antigens through establishment of a polarized cytokine environment. Thus, whereas the immune evasion capabilities and lifelong persistence of herpes viruses are commonly viewed as solely pathogenic, our data suggests that latency is a symbiotic relationship with immune benefits for the host. So essentially, what they showed in their study is that infection with Epstein-Barr virus and cytomegalovirus confers protection against infection with Listeria and Yersinia. Very interesting study. So we're going to discuss the herpes simplex viruses first. And there are two types of the herpes simplex virus, HSV1 and HSV2. Both herpes simplex viruses have a worldwide distribution. HSV1 is more commonly associated with the oral infection that we refer to as cold sores, but it may also cause herpetic keratitis as well as meningitis. HSV2 is more commonly associated with genital herpes. Both are transmitted through direct skin contact and contact with infected secretions. Asymptomatic shedding of the virus is a common phenomenon which can result in transmission of the virus to a new host. Herpes testing is commonly performed using EIA methodologies. Herpes Select is a serologic EIA manufactured by Focus Diagnostics for HSV2 testing. It has a sensitivity and specificity of 99% and 83% respectively. It has a positive predictive value under 50%. In case you're unaware, a positive predictive value is the probability that subjects with a positive screening test truly have the disease, whereas a negative predictive value is the probability that subjects with a negative screening test truly don't have the disease. BioKit produces a rapid serologic EIA for HSV2. Like the Herpes Select assay, it too has a sensitivity and specificity of 99% and 83% respectively. Its positive predictive value, though, is less than 73%. Other tests that are available include PCR, Western blot, and cell culture. Human herpes virus 3 is more commonly known as the varicella-zoster virus, or VZV. It is responsible for causing varicella, which is chickenpox, and herpes zoster, which is shingles. Chickenpox is highly contagious. Approximately 90 to 95% of adults are seropositive. Chickenpox develops following initial exposure to the virus. It is typically a relatively mild, self-limited childhood illness, but can become disseminated in immunocompromised children. For example, those receiving chemotherapy for leukemia or those with advanced HIV infection. Disseminated VZV infection is a potentially fatal complication. Approximately 1 in 4,000 children will develop VZV encephalitis which is an acute neurologic disorder with potentially severe complications. Transmission involves contact with respiratory secretions or direct contact with skin lesions. The incubation period is somewhere between 11 and 21 days. Chickenpox illness usually lasts about 4 to 7 days. The classic symptom of chickenpox is a rash that turns into itchy, fluid-filled blisters called pox that eventually turn into scabs. The rash may first show up on the chest, back, and face, but then spreads over the entire body, including inside the mouth, eyelids, or genital area. It usually takes about 1 week for all of the blisters to scab over. Other typical symptoms that may begin to appear 1 to 2 days before the rash appears include fever, fatigue, loss of appetite, and headache. After the primary infection, VZV remains dormant in sensory nerve roots for life. Upon reactivation, the virus migrates down the sensory nerve to the skin, causing the characteristic painful rash associated with shingles. After resolution, many individuals continue to experience pain in the distribution of the rash, which is a condition called post-herpetic neuralgia. In addition, reactivation of VZV infection can cause a spectrum of atypical presentations, ranging from self-limited radicular pain without rash to spinal cord disease with weakness. Vaccines are available for chickenpox and shingles. The shingles vaccine, Zostavax, has been approved since 2006 for those between 50 and 59, but recommended by the CDC for adults 60 and older. Zostavax offers 70% protection against shingles for people between 50 and 59, but only 18% in people 80 and older, according to the Pink Sheet, which reports on the pharmaceutical industry. Zostavax Zostavax uses a live weakened virus. According to the CDC, the Shingrix vaccine offers 97% protection in people in their 50s and 60s, and roughly 91% protection in those in their 70s and 80s. It appeared to retain similarly high effectiveness throughout a 4-year study period and cut the risk for post-herpetic neuralgia by 86%. Shingrix is a virus particle vaccine and does not contain active virus. Human herpes virus 4, or more commonly known as the Epstein-Barr virus, or EBV. It is responsible for causing infectious mononucleosis and is also associated with Burkitt's leukemia, or lymphoma. Epstein-Barr virus infects and replicates in the epithelial cells of the oropharynx and in B lymphocytes. Transmission of the virus occurs through oral contact with saliva from an infected individual, which is why it is sometimes called the kissing disease. In the United States, as many as 95% of adults between 35 and 40 years of age have been infected. Infants become susceptible to EBV as soon as maternal antibody protection, which is present at birth, disappears. Many children become infected with EBV, and these infections usually cause no symptoms or are indistinguishable from other mild, brief illnesses of childhood. When infection with EBV occurs during adolescence or young adulthood, it causes infectious mononucleosis 35% to 50% of the time. The incubation period is somewhere between 4 and 7 weeks, during which time the patient is asymptomatic, but is still infectious and remains infective for several weeks after symptoms appear. The onset of disease can be acute or insidious and is characterized by fever, sore throat, lymphadenopathy, and fatigue. The acute phase lasts for approximately 2 weeks. The characteristic antibodies begin to appear at this stage. Convalescence and full recovery can take up to several months, but most infections resolve within 4 to 6 weeks. Transmission of EBV occurs by contact with infected saliva and can involve fomites such as toothbrushes, drinking glasses, utensils, etc. EBV only infects a small number of cell types that express the receptor for complement C3d component, which is CR2 or CD21. These include certain epithelial cells, oro and nasopharynx, and B lymphocytes. The virus is replicated in pharyngeal epithelial cells, shed into the saliva, and is taken up by CD21 positive B lymphocytes. B lymphocytes spread the virus through the reticuloendothelial system. Although B cells do not show any histological alterations as a result of EBV infection, they are protected from undergoing apoptosis, or cell death. Once infected, they are stimulated to divide and produce several polyclonal antibodies, EBV-specific, heterophile, and autoantibodies. Autoantibodies can include cold agglutinins, rheumatoid factor, and anti-nuclear antibodies. EBV remains in B cells for life, which is the latency period. In healthy individuals, this process is usually kept in check and asymptomatic. In others, though, the virus can reactivate and go through a lytic replication cycle, and the person becomes infectious again. Although EBV infects mainly B cells, if you recall from hematology class, the body responds with an increase of the lymphocytic population, which are mainly T cells, with typical characteristics called reactive lymphocytes. The white blood cell count is frequently elevated greater than 10,000 per microliter, with an absolute lymphocytosis and greater than 10% reactive lymphocytes. Liver function tests are also frequently abnormal, and IgM heterophile antibodies are present. Epstein-Barr virus has been linked to cancers such as Burkitt lymphoma, especially in Africa where it was first discovered, and to nasopharyngeal carcinomas, especially in Asia, southern China and Southeast Asia. In 1964, Dr. Burkitt, working in Uganda, sent tumor samples to the United Kingdom where Dr. Anthony Epstein and Yvonne Barr first identified the Epstein-Barr virus. A vaccine against Epstein-Barr virus could prevent cancers of this type worldwide. Heterophile literally means an affinity to a different one. Heterophile antigens are antigens that occur on the cells or in the fluids of different species of unrelated animals and microorganisms, Yet the antigens are so closely related that they can cross-react with antibodies formed against any one member of the particular heterophile group. If a heterophile antigen of a particular group is injected into an animal lacking that particular group antigen, the animal will produce a heterophile antibody against that antigen, which will cross-react with the heterophile antigens of that particular group in another species. An animal can demonstrate antigens of more than one heterophile group. Heterophile antigens are either found in certain organs or in the blood. The Forsman antigen is just a particular type of heterophile antigen, nothing more, nothing less. Heterophile antibodies are typically IgM. Depending on the heterophile group of the antigen that stimulates their production, they can be Forsman antibodies against Forsman antigen, or non-Forsman antibodies against one of the non-Forsman antigens. One of the non-Forsman heterophile antibodies that we've discussed in the previous lesson is the reagent antibody produced in response to a syphilis infection. We'll discuss serum sickness in just a bit. The Forsman antigen can be found in horses, sheep, guinea pigs, dogs, cats, mice, most birds, but not all, and some bacteria. Forsman antigen is absent in humans, ducks, rats, rabbits, cows, and monkeys. Some heterophile antigens are capable of lysing sheep red blood cells in the presence of complement. Serum sickness is a type 3 hypersensitivity reaction, an immune response similar to an allergic reaction. When antigens that are sometimes present in certain medications are introduced to the body, they can trigger the immune system to react and produce antibodies. The antigens involved in serum sickness are proteins from non-human sources, usually animals. The immune system recognizes these proteins as being foreign and responds by destroying them. Immune complexes form as a result of the immune response. These complexes can clump together and settle in small blood vessels, which then leads to the associated symptoms. Forsman antibodies are heterophile antibodies formed against any Forsman antigen. As previously mentioned, one of the non-Forsman heterophile antibodies that we discussed in the previous lesson is the reagent antibody produced in response to syphilis. Non-Forsman antibodies are heterophile antibodies produced against any non-Forsman antigen. The antibodies produced in infectious mononucleosis are non-Forsman heterophile antibodies. Most tests for infectious mononucleosis rely on demonstrating the presence of heterophile antibodies of the infectious mononucleosis type, and ruling out interfering Forsman antibodies that can be present in other conditions. Serum sickness antibodies are formed against the foreign proteins present in antitoxins and antiserums made from non-human animal sources. The Paul-Banel test was a screening test for infectious mononucleosis. It was based on the fact that heterophile antibodies have the ability to agglutinate red blood cells of different animal species. The Paul-Banel test used sheep erythrocytes. A series of dilutions were made from the patient's serum and tested with erythrocytes. This test, however, is unable to differentiate between Forsman, infectious mononucleosis, or serum sickness antibodies. The Davidson differential test was developed sometime later to address the problem of cross-reacting non-infectious mononucleosis heterophile antibodies. The patient's serum would be serially diluted, just as with the Paul-Banel test. However, before mixing with the erythrocytes, the diluted serum was first mixed with a solution of guinea pig kidney cells and beef cell antigen to absorb Forsman and serum sickness antibodies. The titer was based on the dilution of the last tube that showed visible agglutination and reported as the reciprocal of that dilution. So, for example, if the last tube showing visible agglutination was diluted 1 to 56, the titer would be reported as 56. A titer of 28 or less was considered normal. A titer of 56 or higher was considered positive and indicated the presence of heterophile antibodies. In infectious mononucleosis, IgM heterophile antibodies are usually detectable for the first 3 months of infection. For the rapid agglutination tests, a drop of patient serum is treated with the prepared guinea pig kidney antigen on one side of the test card. Both are mixed together to allow for absorption of any non-Forsman antibodies. Next, horse erythrocytes are added, which are more sensitive than sheep RBCs. The test card is mixed well and then gently rocked and observed for agglutination. Most test kits today only test for the presence of infectious mononucleosis antibodies. Only 80% of the cases of infectious mononucleosis are positive for IM heterophile antibodies. Only about 50% in young kids. So infectious mononucleosis cannot be ruled out if the test is negative. It may be necessary to confirm those that are negative on the screen to rule out leukemia or lymphoma. Newer tests use latex agglutination. The monospot test uses latex agglutination and is not recommended for general use. The antibodies detected by monospot can be caused by conditions other than infectious mononucleosis. Moreover, studies have shown that the monospot produces both false positive and false negative results. For example, the heterophile antibodies detected by the monospot are often not present in children with infectious mononucleosis. At best, the monospot test may indicate that a person has a typical case of infectious mononucleosis, but does not confirm the presence of EBV infection. False negatives can be due to no heterophile antibodies, which can occur in 5 to 10% of adults and more than 50% of children under the age of 4. False positives can be due to cross-reacting antibodies, as seen with rubella, CMV, viral hepatitis, malaria, autoimmune disorders, and pancreatic cancer. Serum testing for EBV-specific antibodies is the gold standard, but is not a rapid test. The Quick View infectious mononucleosis test is designed to detect IgM heterophile antibodies in whole blood, which is CLIA-waived, and serum or plasma, which is not CLIA-waived. The test consists of the reaction unit, a plastic housing containing a membrane strip which provides solid support for the chromatographic immunoassay. The sample well contains an absorbent pad which provides an even flow of the sample along the membrane. The first zone of the membrane is coated with blue latex beads that are conjugated to goat anti-human IgM antibodies. The second zone of the membrane contains two immobilized agents. One is blue latex beads to provide a pre-printed blue horizontal line, and two, bovine erythrocyte extract. The third zone of the membrane contains an agent capable of binding the antibody blue latex to provide the vertical test complete line. For the test procedure, serum, plasma, or whole blood is added to the add well, followed by addition of the developer. As the sample developer fluid moves by capillary action across the first zone of the membrane, it immobilizes the antibody blue latex. The fluid continues to move with the antibody blue latex across the membrane to the immobilized bovine erythrocyte extract, which is the antigen zone. If specific infectious monoheterophile antibodies are present in the sample, a sandwich of solid phase infectious monoantibody, antibody blue latex is formed. A vertical line will appear, resulting in a positive sign in the read result window. If the antibody is not detected, the read result window will only contain the pre-printed blue horizontal line, indicating a negative result. As the fluid continues to move the antibody blue latex across the membrane, it comes in contact with the reagent in the test complete window. The 5-minute test is complete when a blue line appears. The BioStar Aceva Mono 2 test kit is also CLIA-waived for whole blood and not CLIA-waived for serum and plasma. The test is a rapid chromatographic immunoassay in a dipstick format intended for the qualitative detection of infectious monoheterophile antibodies. Bovine erythrocyte extract interacts with the blood sample. If infectious monoheterophile antibodies are present in the sample, a visible blue line will appear to indicate a positive result. A red line indicates a negative test. 2 drops of whole blood from a venipuncture or fingerstick sample are mixed in a tube with buffer, and the dipstick is placed in the tube. Results are then available in 5 minutes. Besides heterophile antibodies, infectious mononucleosis may lead to the formation of other, more specific antibodies. The following Epstein-Barr virus antigens, VCA, or viral capsid antigen, EA, which is early antigen, and EBNA, which is Epstein-Barr nuclear antigen, may lead to the production of anti-VCA, anti-EA, and anti-EBNA. These can all be tested for, but are not rapid or quick turnaround time tests. Anti-VCA IgM antibodies are detectable early in infection, but with low concentrations and may disappear within 2 to 4 months. Anti-VCA IgG is detected within 4 to 7 days after the first signs and symptoms of infectious mononucleosis and may remain for life. Anti-EA and anti-EBNA appear later but may have several limitations. The EA antigen is comprised of two components, EAD, which is diffuse, and EAR, which is restricted. Anti-EAD IgG is indicative of acute infection, but disappears in about 3 months. Not detected at all in about 10 to 20% of patients with infectious mononucleosis. Anti-EAR IgG may be seen in young children during the acute phase, but are not usually found in young adults during the acute phase. Generally, these antibodies are not consistent indicators of the stage of the disease. Anti-EBNA IgG appears only when the patient is in the convalescent stage of disease. They may, however, be absent in immunocompromised patients. Overall, anti-VCA seems to be the most promising specific antibody. There are a couple of commercially available immunoassays that detect and measure anti-VCA, IgG, and IgM. Reactive lymphocytes, of course, are also associated with Epstein-Barr viral infections. Human herpes virus 5 is more commonly known as cytomegalovirus, or CMV. As many as 40 to 90% of adults carry the virus, and usually without symptoms. However, infection during pregnancy can be extremely dangerous for the unborn child, and screening of maternal blood is important to assess serological status. Cytomegalovirus is the most common virus globally to be transmitted in utero, affecting up to 2.5% of all live births, according to the World Health Organization. Infants may appear normal at birth, but then 10 to 20% go on to develop hearing loss, psychomotor dysfunction, and cognitive disabilities. If symptomatic at birth, infants can show jaundice, hepatosplenomegaly, anemia, low platelet count, and microcephaly. CMV is found in body fluids including urine, saliva, breast milk, blood, tears, semen, and vaginal fluids. Transmission of the virus can occur through contact with saliva or through sexual contact or transplacental transmission. Infections from organ transplant and blood transfusion is also possible. The symptoms of primary infection with CMV is very similar to mononucleosis and is characterized by sore throat, fever, swollen glands, and fatigue. Liver enzymes are frequently elevated. Following primary infection, the virus becomes dormant in white blood cells, which initiates the latency period. CMV usually remains in the host for life. It is often reactivated, but rarely causes serious illness in immunocompetent persons. When reactivated, it migrates to the lymph nodes. From here, it spreads through the epithelial cells of many tissues throughout the body, including the liver, spleen, bone marrow, kidneys, and lungs. Reactivation of CMV during HIV infection can result in serious illness as well as blindness. Viral culture allows isolation of the virus using infected specimens, urine, respiratory secretions, and anticoagulated whole blood. Once present in culture, the virus can be detected via direct immunofluorescence assay. Fluorochrome-linked antibodies are added to the tissue culture. Viral culture and molecular tests are used to detect active infection in immunocompromised or in congenital infections. Serology is best for detecting past exposure to the virus or those at risk for future exposure, such as pregnant women or transplant candidates. This is also done with blood and organ donors. Most assays detect IgG, as there are limitations with IgM assays, such as the inability to differentiate a new infection from reactivation. Many rapid screening tests utilize latex agglutination. Latex particles previously sensitized with CMV viral antigen are mixed with patient serum. If antibodies, either IgM or IgG, are present, the agglutinated particles will be macroscopically visible. In the absence of antibody, or with very low titers, the particles will not agglutinate, but appear smooth and evenly dispersed. The procedure can be performed qualitatively on undiluted serum to determine the presence of antibodies to CMV. Quantitative procedures using serial two-fold dilutions can be performed to determine the CMV antibody titer. This is usually done on a baseline sample, then repeated at 2 weeks to detect a rising titer. We're looking for a four-fold or greater increase, which indicates active infection. Molecular diagnostic techniques such as DNA probes and PCR are also available for detection of the CMV virus itself. If you recall back from the first lectures of this term, avidity is the overall strength of the antigen-antibody binding reaction and is therefore a measure of stability. IgM by itself is not diagnostic for primary CMV infection due to potential for IgM to be present in reactivation or to linger. Primary infection is IgM present along with IgG antibodies of low avidity, whereas secondary infection, IgM may be present along with IgG antibodies of high avidity. Because most adults are positive for CMV antibodies, the method of choice for detecting active infection is viral culture. The virus may be detected in a positive culture by direct fluorescent antibody examination. While positive cultures are reliable for confirming an active CMV infection, negative results are inconclusive. Furthermore, culture lacks sensitivity since the virus is shed only intermittently during the early stages of infection. Serologic tests for antibodies, both IgM and IgG, by indirect ELISA or indirect immunofluorescence are supportive in the diagnosis, but do not stand alone. Detection of IgM anti-CMV indicates active infection, but cannot distinguish between a primary infection and reactivation of a latent infection, as IgM is present in both. Demonstration of an increasing titer of CMV-specific IgG suggests, but does not confirm, an active infection, either a recent infection or reactivation of a latent infection.